Hello, and welcome to today's presentation on the aerosolized medications provided by the Respiratory Care Services Department at Stanford Healthcare. Satisfactory completion of a post-test and skills checklist will be used to demonstrate respiratory care practitioner competency in the administration of aerosolized medications. This educational module will be revised as nebulized medications are added or removed from formulary at SHC. All materials contained within this module will be reviewed at least once every 3 years. As a respiratory care practitioner working in an academic medical center, you can expect to receive orders to nebulize medications not discussed within this module. To ensure medical director approval for an ordered procedure and to get advice for administration, consult a supervisor when asked to nebulize medications not discussed in this module. By the end of this video, the viewer will understand the indications for commonly ordered nebulized medications. The potential side effects and the precautions one should use when administering these medications will also be discussed. The learner will review what type of equipment should be used for the administration of each of the nebulized medications. The learner will also be able to explain why some medications, which are commonly given at other facilities, are not offered on formulary at SHC. Finally, the learner will review the correct method to prepare colistin for nebulization. Intermittent nebulizer therapy with albuterol can be used for patients with less acute bronchospasm resulting from small airway muscle constriction. Use the blue labeled unit doses to administer albuterol by itself. The pink labeled unit doses can be used for mixing albuterol with other medications like Atrovent or Pulmicort. Levalbuterol, or Xopenex, was once believed to cause fewer cardiac side effects than albuterol. However, a study published in Chest in 2011 found that neither albuterol nor levalbuterol caused significant tachycardia or arrhythmias. Xopenex represents a medication that costs significantly more than albuterol sulfate without apparent relative benefit. Therefore, at SHC, Xopenex remains a non-formulary medication available to patients only with pharmacy approval or for patients using their own medications. Ipratropium bromide, or Atrovent, is a common anticholinergic medication used either as a maintenance therapy to guard against bronchospasm in patients with COPD or to dry a patient's respiratory secretions. Atrovent acts more slowly than albuterol, but the effect lasts a bit longer. Atrovent can dilate pupils and dry or irritate a patient's eyes. Therefore, administration with a mask or via continuous nebulization should be avoided. If Atrovent must be administered via mask, the patient should be told about the possible ocular effects. The combination of albuterol and Atrovent has been shown to have greater effect than the administration of either product given alone. Duoneb is frequently administered at SHC to treat acute bronchospasm, especially in patients with COPD or asthma. Many of the medications already discussed are available for home administration with an inhaler. However, inhalers typically contain up to a month's worth of medication, and since an inpatient cannot leave SHC with their assigned inhaler, inpatient use leads to medication and environmental waste. To minimize this waste, SHC will automatically convert any ordered inhaler to the comparable nebulizer solution, frequency, and dose. Unless a patient is using his or her own medication, all bronchodilators will be administered via nebulizer. Orders for Spiriva, a once-daily maintenance drug for COPD, will be changed by pharmacy to QID nebulization with Duoneb. Since most patients with Spiriva orders already take Spiriva at home, patients may be encouraged to use their own medication and home regimen during their hospital stay. Racemic epinephrine, one of the first bronchodilators available for commercial use, is still on formulary at SHC for its vasoconstrictive alpha effects. Patients who have stridor due to pharyngeal or laryngeal swelling may benefit from administration of aerosolized racemic epinephrine. Recommend racemic epinephrine for patients with post-extubation swelling, croup, or epiglottitis. 3 milliliters of 4% lidocaine solution is typically nebulized to numb the oropharynx before procedures like bronchoscopy or the placement of nasogastric tubes. However, recent literature also demonstrates benefit for treating bronchospasms in patients with steroid-resistant asthma. It may also be beneficial for patients with uncontrollable coughing. Palliative care physicians may increasingly order lidocaine for cough in patients with end-stage cancer. Hypertonic saline, available in either 3%, 7%, or 10% concentration, is often used to improve mucus clearance in patients with cystic fibrosis. It is also frequently nebulized to induce a sputum specimen for analysis by the laboratory. Mucomist is commonly nebulized at other facilities to improve bronchial hygiene. Acetylcysteine breaks disulfide bridges within mucus and replaces them with weaker sulfhydryl bonds, resulting in thinner mucus. However, in vivo studies fail to demonstrate the efficacy of aerosolized acetylcysteine. Further, mucomist degenerates to an acid when it hits the respiratory mucosa, leading to airway inflammation and bronchospasm. Because of the risk of side effects, coupled with little evidence to support efficacy, nebulized acetylcysteine has been removed from the formulary at SHC. Why do cystic fibrosis patients need Chinese hamsters? Because an enzyme made in the ovarian cells of Chinese hamsters is the primary ingredient in pulmozyme, which is routinely used for bronchial hygiene. Pulmozyme cleaves the long DNA chains found in sputum of patients with cystic fibrosis and clears extracellular DNA from the airway lumen. Other medications may denature the enzymatic action of pulmozyme, so a dedicated nebulizer should be used. Recent studies demonstrate that pulmozyme and tobramycin can be given together in a peri-nebulizer without negatively impacting either medication. However, the Cystic Fibrosis Foundation continues to recommend patients receive their medications and therapies in the following order. Nebulized bronchodilators are given first, followed by mucokinetic medications like pulmozyme. Next, the Cystic Fibrosis Foundation recommends a patient undergo any ordered airway clearance techniques. Finally, antibiotics like tobramycin should be given. Budesonide, or Pulmicort, is the most common steroid used at Stanford Healthcare for airway maintenance. It is available in either 0.25 milligram or 0.5 milligram doses and may be administered together with albuterol. Use the pink-labeled unit doses of albuterol when administering it with Pulmicort to minimize total solution volume and administration time. QVAR and other inhaled steroids will be automatically converted to the appropriate dose and frequency of Pulmicort to reduce medication and environmental waste. Patients should be encouraged to orally rinse after any steroid administration to help prevent the development of oral thrush. The Aerogen system remains the first choice of nebulizer for all patients receiving invasive or non-invasive ventilatory support. However, non-intubated patients requiring intermittent nebulization with the medications previously discussed should use the AeroEclipse 2 breath-actuated nebulizer to maximize deposition and penetration in the functional units of the lung. The AeroEclipse nebulizer delivers a high respirable dose and optimal particle size to reach therapeutically important areas of the lungs. Studies comparing the AeroEclipse to conventional jet nebulizers showed improved deposition when the AeroEclipse was used. The majority of medication from traditional nebulizers deposited in the patient's throat or in the patient's stomach, with 72% of the medication depositing in the patient's lungs with the AeroEclipse. Breath-actuated technology reduces the amount of drug lost to the environment when the patient exhales. It also maximizes the dose delivered to the patient, which may potentially reduce time spent in the emergency department and admission rates. The AeroEclipse also leads to more efficient treatment times due to its ability to administer a higher dose of medication in less time. Studies show that the MicroMist nebulizer previously used at Stanford Healthcare delivered approximately 133 micrograms of albuterol in the first 4 minutes of use. Extrapolating this to 8-minute administration time suggests that even after a full treatment, a patient can expect to receive only 10% of the ordered dose of albuterol. Compare this to 293 micrograms delivered in only 3 minutes with the Aero Eclipse. In other words, an RCP can deliver more medication in 3 minutes with the Aero Eclipse nebulizer than he or she could using a micromist neb for the full 8-minute nebulization time. This allows the respiratory care practitioner greater flexibility in care. For example, routine nebs can be given in 3 minutes. However, running the Aero Eclipse for a full 8 minutes gives almost 3 times the dose that a patient would receive with the micromist. Therefore, a patient who is extremely short of breath may benefit from a full 8 minutes with the Aero Eclipse as compared to 8 minutes with the micromist or even with the large volume continuous nebulizer. However, for patients who cannot trigger the device, the Aero Eclipse can be operated in continuous mode by rotating the mode switch 90 degrees clockwise to the continuous mode position. In this mode, the nebulizer may be fitted to a standard aerosol mask using the Aero Eclipse elbow adapter. By removing the mouthpiece, the RCP can also connect the Aero Eclipse directly to the Aerobica for inline flutter valve treatments. A proprietary one-way valve provides protection for clinicians and family members against second-hand aerosol exposure. However, for a patient with a tracheostomy tube, this one-way valve can hinder exhalation. For patients with a tracheostomy tube, the Aero Eclipse can be run in continuous mode via a trach collar to facilitate exhalation. By switching to the Aero Eclipse breath-actuated nebulizer, respiratory care practitioners will also have to change equipment less frequently. Patients with cystic fibrosis will still have their nebulizers changed daily in accordance with the recommendations of the Cystic Fibrosis Foundation. However, all other patients can now use the Aero Eclipse for up to a week between changes. Simply shake any excess medication from the device and allow it to air dry between administrations. Advair combines a long-acting beta-adrenergic drug with a steroid for maintenance therapy in COPD. Advair is not effective as a rescue inhaler and should not be used in acute attacks. Advair is given using a proprietary dry powder inhaler discus. The medication is loaded by clicking the purple lever to the right. Once loaded, the discus should be held flat so no medication spills. The patient exhales fully, raises the discus to the mouth, and takes a quick, deep inhalation through the mouthpiece to pull the medication into the lungs. Patients should be encouraged to orally rinse after any steroid administration to help prevent the development of thrush. The U.S. Department of Labor Occupational Safety and Health Administration has specific instructions for protecting oneself when administering antibiotic, antifungal, antiprotozoal, or antiviral medications. Although the risk of secondary exposure is low, unintentional inhalation of fugitive aerosols can occur when the nebulizer mouthpiece or mask does not properly fit, or when separated from the patient's mouth. For example, when the patient is coughing. Secondary exposure can cause eye irritation, can irritate or numb nasal passages, or exacerbate asthma. Therefore, OSHA instructs caregivers to wear an N95 mask or a capper during the nebulization of any of these medications. Visitors should be asked to leave the room during administration with these types of medications. If visitors choose to stay in the room during nebulization of antimicrobial agents, they should also wear an N95 mask. Ribavirin is an antiviral agent used in the treatment of patients with respiratory syncytial virus. Ribavirin requires special handling and cleanup procedures along with specialized equipment, the spag, and demystifier tent. Ribavirin is now a non-formulary medication that requires pharmacy approval of any order. As it is seldom given, it is considered a high-risk, low-occurrence procedure and will have a separate, dedicated educational module and competency. Please contact a resource therapist or supervisor should you receive an order for ribavirin administration. Tobramycin is an antibiotic that is commonly used to treat Pseudomonas infections or pneumonias in patients with cystic fibrosis. Tobramycin is given with a filtered IsoNeb nebulizer. Use a new IsoNeb on every administration and discard the filters and the nebulizer when the patient completes his or her treatment. Immunocompromised patients risk infection from invasive Aspergillus fungus. SHC has a large population of patients who undergo solid organ or bone marrow transplants, intensive chemotherapy, or who suffer acute myeloid leukemia. These patients may require treatment or prophylaxis with aerosolized amphotericin. Colistin is an antibiotic that can be nebulized to treat hospital and ventilator-acquired pneumonia, especially those caused by multi-drug resistant gram-negative bacteria that has not responded to treatment with systemic antibiotics. Nebulized colistin may also be used to treat infection with Pseudomonas aeruginosa, Klebsiella pneumoniae, and Acinetobacter baumannii. Colistin has a short shelf life, so the nebulizer solution is prepared by the respiratory care practitioner immediately before administration. To prepare, first perform hand hygiene and find a clean surface upon which to work. Retrieve a 150 mg colistin vial and a 10 ml normal saline vial from the patient's medication bin. Scan the patient's identification band and the bar-coded labels on the side of the colistin and saline vials to record administration in EPIC. Remove the plastic caps from each vial. Wipe the rubber tops with an alcohol swab and let air dry. Using a syringe with attached needle, withdraw 4 ml of saline and inject the saline into the colistin vial. Swirl the colistin vial gently until all the crystal deposited at the bottom of the vial disappears. Do not shake the vial, as the solution will become foamy. Transfer solution to a nebulizer for immediate administration. Any unused colistin must be discarded if not administered within 1 hour from preparation. The previously discussed antimicrobial agents require the respiratory care practitioner to wear an N95 or capper device when administering. To further protect the RCP from fugitive aerosol particles during patient expiratory phase, a filtered IsoNeb type nebulizer is used. A series of one-way valves and filters prevent the aerosol from entering the room during the patient's expiratory phase. The patient should also be coached to hold the mouthpiece firmly between the lips for the entirety of the treatment. The patient should also be instructed to cover his or her mouth when coughing. Tyvaso and Ventavus are epiprostenol medications that patients use at home to manage chronic pulmonary hypertension. The patient fills a proprietary nebulizer with a single unit dose of medication that is inhaled for a few breaths several times throughout the day. At Stanford Healthcare, Tyvaso and Ventavus are not administered by respiratory care services. Rather, the patient continues using his or her own medication following his or her own home regimen. Appendix A of the procedure on the portal gives an alphabetical and color-coded listing of commonly nebulized medications. Those color-coded in green are available at SHC and carry minimal risk associated with administration. Those listed on a yellow background are also available at SHC, but require special equipment or procedures. Medications on an orange background are also available but require greater care to administer safely. Finally, those medications listed on red backgrounds are not available for routine nebulization at SHC, despite possibly being used at other facilities. The last column of red labeled medications gives the reasons why that medication is not available at SHC. When providing treatment with aerosolized medications, always practice the principles of CI care. Let the patient and family know what we hope to accomplish and communicate the plan for further treatments. Never leave a patient unattended while administering aerosolized medications. Individual RCP workloads are designed to prevent the need for concurrent therapy. However, as patients are admitted or discharged, workloads can change. If you find yourself falling behind on an assignment, please contact the crisis therapist to assist. If there is no crisis therapist available, try the resource therapist or supervisor. If you still are unable to get help, patients should be triaged from highest to lowest clinical need. Patients with the highest need should be seen first, and those with the lowest may need to be skipped. If staffing requires some patient treatments to be skipped, please document this on the electronic medical administration record, let the bedside nurse know, and alert a supervisor. Skipping a less acute patient is preferable to trying to perform all listed procedures by providing treatment to more than one patient at a time. Document all aerosolized medications administered in compliance with medication safety standards. Scan the barcoded inpatient or emergency patient identification band to access the electronic medical record in Epic. Scan the medication barcode to record an administration. A full respiratory assessment, including patient's level of consciousness, pulse and respiratory rate, oxygen device and saturation, and breath sounds, should be completed and documented upon the initiation of a treatment. A reassessment of previous parameters, along with patient's tolerance and appearance of any adverse effects, should be noted upon completion of therapy or at least every hour when on continuous nebulization of albuterol in the emergency room. Adverse effects or changes in patient condition that require new orders should be communicated to the patient's care team. Record any communication with a physician or other member of the team in the patient's electronic medical record. Use the appropriate procedures to record administration, assessment, and communication during periods of IT downtime. Syringes, medication vials, and diluent vials used to prepare colistin, pentamidine, or continuous albuterol solution should be discarded in a Sharps container immediately after the solution has been transferred to the nebulizer. Aerogen nebulizers positioned in line with ventilator or BiPAP units need only be changed once every 28 days or when visibly soiled or poorly functioning. The large volume heart neb used for continuous nebulization of albuterol, or the isoneb type nebulizers used to administer antimicrobial medications, should be discarded after every treatment. Shake all residual solutions from other nebulizers and allow to air dry between treatments. Change the nebulizer daily for patients who have cystic fibrosis. For all other patients, change the nebulizer at least once a week or when visibly soiled. This completes our presentation on medications available for nebulized use at SHC. Please direct any questions to the Respiratory Care Services Department. Thank you.